Our dear guest, Professor Mohamed Jaloudi. He's Professor of Clinical Oncology in Swam Hospital in United Arab Emirates. He will speak to us now about management of bone health in the context of hormone therapy. Please, Mohamed.
Bismillahirrahmanirrahim. Good morning. Thank you for the invitation to the organizers and especially my good friend Dr. Hisham Al-Ghazali. It's always a pleasure and a treat to come to Egypt. I'm not Egyptian, but I feel like I'm Egyptian in heart, and it's always great to come back to the creator of civilization and society, where everything we know in the modern era has started in Egypt. And if Egypt is strong, all of us as Arabs are strong. So, Tahya Masr. Tahya Masr. So with that said, my topic might be a little boring. It's probably going to confuse you in the beginning. Hopefully not. I'm confused. But hopefully with the last 2-3 slides, it'll all basically make sense. I'll talk about the management of bone health in the context of hormonal therapy, whether impacting on bone mineral density, or I'll touch more about the impact on outcomes such as disease-free survivals or overall survivals. I'll be talking about the adjuvant setting, so metastatic bone metastases is a different topic. We know all the data and results from bone-targeted therapy in metastatic disease. That's pretty obvious. So we'll touch upon just basically the adjuvant treatments, whether bisphosphonates or the rank ligand inhibitors. I guess the battery's dying here. Remember that there is naturally occurring bone loss with the aging process, but also there is a progression of bone loss with some of the consequences, regardless of age, such as the treatments we do, whether it's AI therapy, which was touched upon, for prostate cancer, androgen therapy, and chemotherapy. And if you look at the steroidal and non-steroidal AIs as compared to tamoxifen, we know that they increase the fracture risks compared regardless of which AI, and you can see the significance in the p-values from some of the major trials. And look at the percent increase again of some of the major trials with the use of aromatase inhibitors as compared to tamoxifen, and you can see in one of the trials it's 113% increase in the risk of fractures. عشان أنا مش مركز. Okay, so sorry about that, but okay. So again, adjuvant therapy, bone loss naturally occurring, and the fracture rates, and the increased risk with the AIs. So what can we do to prevent some of these fractures in early breast cancer and the bone integrity of the bone itself? Also, remember some of the predictors of fracture risk based on the DEXA scan, the age, drugs, smoking, and so on, and all these factors, vitamin D deficiency. As you know, most of the, at least where I work in the Gulf region, most of the women are vitamin D deficient, so always think of that and measure it. We'll start with the ZOFAST trial. This is a phase 3 trial of use of zoledronic acid with adjuvant letrozole. It's letrozole plus immediate zoledronic acid versus delayed zoledronic acid. Again, I'm going to touch initially about the effects on the fractures and bone mineral density. I'll talk about the outcomes and survivals or disease-free later on. So you will see the same trials again in a different setting. And you can see that for the immediate zoledronic acid as compared to the delayed, there was a significant p-value showing there is a benefit when it comes to the change in the lumbar spine bone mineral density. So there is a benefit that is significant. The ABC-SG12 phase 3 trial again, adjuvant endocrine therapy plus or minus zoledronic acid, randomized to 4 arms, tamoxifen and anastrozole, versus the same with the addition of zoledronic acid every 6 months. And again, you could see that there was a substantial change in the bone mineral density at 3 years, and again at 5 years, showing there is definitely a gain and a benefit with the addition of zoledronic acid as compared to no zoledronic acid. And the benefit was for both the arms with either the tamoxifen or the aromatase inhibitor. At 5 years, the benefit was still there and greater for the zoledronic acid, though at 5 years, the patients who did not receive the zoledronic acid, there was an improvement in the bone mineral density in those patients, but not to the baseline. What about denosumab? We're using it more and more, the rank ligand inhibitor. In a preliminary trial, it shows that addition of denosumab as compared to placebo, there is definitely a change and improvement in the bone mineral density, and this difference was great at 5.5% at 12 months, and again, even greater at 24 months. Then came the ABC-SG18 trial. This is adjuvant denosumab, prospectively randomized trial of 3,400 patients. The primary endpoint was the time to first clinical fracture, and there were secondary endpoints we'll talk about later. And you can see, again, this was statistically significant with a hazard ratio of 50, or a risk reduction of 50%, which is pretty impressive, and a p-value of 0.0001. And this was maintained, and actually the lines diverged even further at 72 months, with improvement in the patient populations who received the denosumab in the risk of fractures. For this ABC-SG18 trial, so adjuvant denosumab at 60 milligrams twice yearly significantly decreased the new clinical fractures, improved bone mineral density at the lumbar spine, and so on, reduces new and worsening of pre-existing vertebral fractures. Patients with the normal baseline bone mineral density showed similar fracture risk and similar benefits from denosumab as compared to the patients with a baseline T-score that was below -1. So remember, for patients who are undergoing treatments with aromatase inhibitor or have underlying osteopenia or osteoporosis, you should have a checklist, and patients who would benefit from these agents should be given these drugs, whether it's denosumab or zoledronic acid or even some of the oral bisphosphonates, and I'll show you later for oral bisphosphonates that they're probably similar to the intravenous bisphosphonates. Have a checklist, check the T-scores, and especially if they're on the aromatase inhibitors, probably they need to be on supplementation along with the calcium and the vitamin D. Remember that definitely postmenopausal women, but you know, we know the value of aromatase inhibitors in postmenopausal women, and tamoxifen might be of benefit in postmenopausal women in increasing the bone mineral density, but tamoxifen in the premenopausal women actually is detrimental, and it decreases the bone mineral density as compared to postmenopausal women. There are guidelines, whether it's the NCCN or the European guidelines, in when to measure T-scores and when to intervene pharmacologically or just with supplementation. That's pretty straightforward. Let's move to the main topic, which is, should we be using bone modifying agents as part of adjuvant therapy to impact on breast cancer outcomes, whether disease-free survival, overall survival, or not? You know, there's conflicting data. There have been no less than 4 meta-analyses. Some of them were positive, some of them were negative. There have been a few trials that showed some improvement in one patient population as compared to the other patient population. But what do we do in real life when we are faced with such patients? We'll start with the early adjuvant trials. You can see these 4 trials. Again, there were conflicting data with the initial trial, with DEAL. Small trial, 300 plus patients. In that trial, it showed benefit in disease-free and overall survival with the oral clodronate as compared to placebo. Another trial with Sarto, there was no benefit. Another trial with Christensen, no benefit. And then the Powell's trial, which was 1,000 plus patients, oral clodronate for stages 1, 2, and 3. And in this trial, there was a benefit in disease-free and overall survival, but for which patient populations? So we'll go through this Powell's trial. Again, this is stage 1 to 3 cancers, 1,000 plus patients, and you could see that the bone metastases-free survival in the intent to treat population, there was a significant difference with the addition of the oral bisphosphonate. Also, in the overall survival, there was a significant benefit as compared to the placebo. The NSABP 34 trial, again, another phase 3 study of adjuvant clodronate in breast cancer. Primary endpoint was disease-free survival, and women with stages 1 and 2 breast cancer receiving adjuvant standard therapy, 3,300 patients, clodronate versus placebo. And in this trial, as compared to the Powell's trials, disease-free survival was the same, whether you received the clodronate or the placebo. As I've been telling you, there's conflicting data, and what should you do? But look at the subset analysis of the B34 trial. There was no difference in disease-free survival or overall survival. But if you look at the non-bone metastases-free interval, there was a significance. Now, that doesn't make sense because you're giving a targeted agent for bones, yet the bone metastases-free interval was not impacted. The non-bone, meaning visceral metastases, was impacted. So maybe these drugs have some anti-tumor activity. They're changing the milieu of the cancer itself, and they might impact not just the bone, but also the visceral. So maybe there is some anti-tumor activity. Probably is. But the concept of, preventing the bone metastases, at least in this trial, was not there. It actually decreased the visceral metastases. Again, subset analysis of this trial, and you can see by recurrence-free intervals, it benefited basically patients who, regardless of ER, PR, one or more nodes or not, but the patients who were under the age of 50, so the premenopausal kind of patients, usually do not benefit, and this was basically the same theme in most of the trials. Another small trial which is very confusing, I just put it for completeness, a combination of epirubicin, paclitaxel, cyclophosphamide, and another arm with the addition of capecitabine. They added also erythropoietin and ciprofloxacin. Very complicated, but they used ibandronate. I just show it to show you the other oral agent, which is ibandronate in one arm and placebo in the other arm, and basically the lines are superimposed. There was no benefit. Let's go back to the ABCSG12 trial. We mentioned it before about the bone and fractures. Let's talk about the outcomes. So this is the 4 arms: anastrozole, tamoxifen, plus minus the zoledronic acid. And the 84 months disease-free survival in women who received the adjuvant endocrine therapy plus zoledronic acid. And you could see there was statistical significance when it came to disease-free survival as well as overall survival, with the p-value of 0.14 and 0.049 for the overall survival. Again, there was a difference in the events such as the secondary malignancies, contralateral breast cancer, distant recurrence, and local regional recurrence in favor of the arm with the zoledronic acid. Again, the age and the effects on disease-free survival, you could see that patients who were younger, premenopausal or younger than 40, did not benefit. Patients who were over 40 showed a statistical difference and hazard ratio of 66. Another trial, so this trial was positive, but another trial which confused us even more is the AZURE trial. This is a phase 3 trial of adjuvant zoledronic acid in high-risk patients, localized breast cancer, women with stage 2-3 breast cancer to standard therapy versus zoledronic acid, 6 doses Q3 to 4 weeks, followed by 8 doses Q3 months, and then 5 doses Q6 months. And in this trial, disease-free survival and overall survival was not significant as compared to the other trial. But if we substratify some of these patients, perhaps there is a difference. And you look at the patients who were pre or perimenopausal, younger patients, as compared to the patients who were postmenopausal and more than 5 years postmenopausal, and you could actually see that there is some statistical significance. What about treatment effects on first bone recurrence? Again, and you could see there is no difference whether they were perimenopausal or postmenopausal, so they were the same. But the invasive disease-free survival, so the invasive part, not the DCIS, recurrence outside bone marrow based on menopausal status, now that was different, showing there is a benefit in patients who were more than 5 years postmenopausal. There was no benefit in the younger patient populations. Again, effects on menopausal status and outcomes, and you could see the older you are, the more further away from the menopause, the more likely you will do better when it comes to the invasive disease-free survival. But again, the overall survival, as I mentioned, for the whole subset of patients was not significant. Basically, you should choose the patients who were postmenopausal and 5 years beyond postmenopause to see some benefit. To conclude the AZURE trial, basically, adjuvant zoledronic acid did not improve disease-free survival in the broad stages treated with adjuvant therapy. Zoledronic acid used in this schedule does not have any broad applicability to the adjuvant treatment of early breast cancer. The AZURE results are strikingly different to those we just seen with the ABCSG12, and in a pre-specified subgroup, high significant heterogeneity of effect on the menopausal status was seen, where patients who were older had improvement in overall and disease-free survival. Another trial, the ZOFAST trial, with letrozole and zoledronic acid, and this is the final 5-year final analyses, treatment duration of 5 years. And you could see that in this trial, the ZOFAST trial, there was significance in the disease-free and overall survival. If you look at all these trials and you put them together and see there are variations, there are some similarities, but you could see that the ABCSG12 trial, there was significant p-value, but the trial I just mentioned, the AZURE trial, there was no difference, and some of the other trials which were smaller, there was no difference. So there's variability. If you subclassify them into the menopausal status, so postmenopausal patients, that makes more of a reasoning. AZURE trial, ABCSG12 trial, the ZOFAST trial, and the ZFAST trial, showing there is a benefit in postmenopausal patients as compared to pre- or perimenopausal patients. A trial from last year, the SWOG SO307 trial, compared the different bisphosphonates that we have available, oral or intravenous, clodronate, ibandronate, and zoledronic acid. There were 6,000 plus patients in this stage 1 to 3. 58% of these women were postmenopausal. Adjuvant treatment for 3 years. There was no difference in the 5-year disease-free survival and overall survival between the 3 arms. There were higher grade 3 and 4 toxicities with the ibandronate. There was slightly higher osteonecrosis of the jaw with the zoledronic acid at 1.2%. Clodronate was 0.6%, and ibandronate was 0.3%. The fault with this trial, that it showed there is improvement in 5-year disease-free and overall survival. There was no control arm, so all the patients got bisphosphonates, whether oral or intravenous, but there was no control arm to say that we should be doing this as a standard of care. And in this trial, there was a patient preference as well. 73% of the patients preferred the oral bisphosphonates. As I mentioned before, there were 4 or 5 meta-analyses. Some were positive, some were negative. I'll just show you the last one from 2015, showing over 18,000 patients, treatment duration of 2 to 5 years, follow-up of 5 to 6 years, and premenopausal patients, in this case, there was absolutely no effect. But for the postmenopausal patients, you could see there was significant p-value differences with the local recurrence, distant recurrence, breast cancer mortality, and bone recurrence. On the other hand, meta-analyses in 2010, 2012, and 13 did not show any significant benefit. Remember that adjuvant bisphosphonate treatments, there might be some patients who would benefit. Postmenopausal, age greater than 50, ER negative, showed more benefit. High-grade tumors, time is up, okay. 2 minutes. Now we stopped, remember?
You
We had a
can
break.
continue. اتفضل كمل.
Sure. مش ماشي. Okay.
هيتعدل دلوقتي.
Okay. So finally, impact of adjuvant denosumab on disease-free survival. I showed you the ABCSG18 on the outcomes in bone mineral density and fracture rates. This is from the San Antonio a month ago, and showing that results of the disease-free survival in the intent to treat analyses, as you go down in years, up to 90 months, the interval is improving, and there is definitely a benefit with a significant p-value in patients who receive denosumab. Even if you censor for crossover, the benefit is even greater. All subtypes, all subgroups had a benefit, especially the older patient populations. Higher grade tumors, so tumors greater than 2 centimeters, had even a greater benefit. And patients, subgroups, both ER and PR positive, also had a significant benefit as compared to the ones with the other trials, which were mostly ER negative. If you compare these two, and you should never cross-trial compare, but compare the ABCSG18 trial with the ABC-TCG meta-analysis I just showed you, and it showed similar results. Patients who received bisphosphonates in the other meta-analyses compared to this trial with denosumab, patients did have some great benefit. To summarize the ABCSG18 trial, this time-driven disease-free survival analyses indicate that the adjuvant denosumab improves disease-free survival. Adjuvant denosumab is relatively safe. 60 milligrams q6 months reduces the risk of disease recurrence or death in postmenopausal patients. The observed disease-free survival of adjuvant denosumab is similar to the meta-analyses, and this benefit comes in addition to significantly reducing the clinical and vertebral fractures and improves the bone mineral density. So finally, patients receiving adjuvant treatment for early breast cancer are at increased risk of adverse bone health. Bone-targeted treatments at osteoporosis doses prevent cancer treatment-induced bone loss.